So you'll notice that there's nothing under congenital anomalies because it's in this chapter. We wanted you to be aware that, yes, we see it. We're not testing over it in this lecture. We've included those congenital anomalies in each system as they apply, okay? So the last two things I want to talk about are inborn errors of metabolism and meconium aspiration syndrome. A newborn screen is performed at least 24 hours after adequate intake is established. So if that baby's not eating well before they go home, they may need that newborn screen repeated. If they're breastfeeding, remember that breast milk does not fully come in for a few days. And so if that baby's breastfeeding, they may need that initial newborn screen repeated. So what is the newborn screen looking for? Well, now they've added a lot of other things. Some states screen for sickle cell and cystic fibrosis and various things. But initially, it started out as looking for PKU. And then as other disorders were discovered or they figured out ways to test for them, they were added to that. Inborn errors of metabolism are genetic disorders in which a person does not produce. Usually it's some kind of enzyme. They don't produce something that's necessary to metabolizing a particular nutrient. In the example of PKU, they cannot metabolize phenylalanine, and so it builds up in their systems. There are multiple inborn errors of metabolism. They all have different management and outcomes. Most of them are managed with a special diet, but there are some that it's actually impossible to manage because the thing that the person cannot process is something that's required for life. So the big thing we want to do is make sure that PKU or that newborn screen gets done, because for most of these, if we're not managing it early, that child is developing some kind of damage, and frequently that's neurologic damage, and it can be prevented or minimized by an appropriate diet, okay? And the last thing we're talking about is meconium aspiration syndrome. And we actually talked about it just a little already. It's a chemical pneumonia caused by aspirating meconium that was passed in utero. It inflames the airways. The meconium blocks the alveoli and doesn't allow them to expand and doesn't allow for gas exchange. That means that the lungs, because they're inflamed, it's harder to pump blood through the pulmonary vessels, so we can have pulmonary hypertension. Because we keep a right to left shunt, because the lungs are all inflamed, so the pressure is higher on the right side, we keep a right to left shunt. That means we can maintain those circulatory bypasses, the foramen valve and the ductus arteriosus. Management. There is a device called the Meconium aspirator that's actually attached to suction, and it is used only if the infant is not responsive. They use that Meconium aspirator, get out as much as they can before they begin resuscitation. If the baby is responsive at delivery, we just clear the mouth and nose the best we can and monitor the respiratory status, and then provide supportive therapy. Okay, you have made it through complicated newborn. We will see you next week.